हाँ जी. Hello everyone. Let's do the test discussion for your FMG exam. Well, all the questions what I've taken, they are taken from the previous FMG exam, so that you are exactly getting all the discussion about the question which are actually asked in your FMG exam. So we have a question number 1. In type 2 respiratory failure, there is, what is the correct answer? So answer of this question is B is the answer. Well, now let's discuss the question in detail. First of all, we all know very well normal. Let's learn the basic concept. Basic concepts, which I'll be writing as BC. Well, normal PaO2 is somewhere around 94 to 104. And normal PaCO2 is 40 to 45 millimeter of mercury, right? Well, this is the partial pressure of normal oxygen and CO2. Now, whenever this PaO2 is below 60 millimeter of mercury, we call as hypoxia. Is also known as respiratory failure. So you mean to say this very, very important point. This is the golden line to remember. Okay. So that means the partial pressure of oxygen goes down. We are talking about respiratory failure, we call as hypoxia also. Now we have two types of respiratory failure, type 1 and type 2. PaO2 and PaCO2. In type 1, it is less than 60. Partial pressure of oxygen is less than 60. And the partial pressure of the CO2 is again less than 40. That means, in nutshell, there is hypoxia and hypocarbia. Hypocarbia means CO2 is less than normal. But in type 2, it is hypoxia is there. PaO2 is less than 60. But PaCO2 is more than 45. You remember the normal PaCO2 is between 40 to 45. So that means when we talk about difference between type 1 and type 2, major thing is it is the CO2 level, 40 and 45, less than 40 and more than 45. But remember, this is common, same, 60-60 is common. Okay, so with this background of basic concept, now if you look into the option, so we are very clear about it, why this is the right answer. Do we get, yes, we do get low CO2, low O2, but low CO2, this we get in type 1 failure, not in type 2. And this is not seen in type 2, because in type 2, it should be reduced. So now this is the best answer. Low CO2, normal PaCO2 is again a wrong answer. So now you are clear about it, why the right answer is B, Bombay. Okay. Now we talk about the following pulmonary changes are seen in restrictive lung disease except. Answer is vital capacity is increased. This is not the answer. Again, we go to basic concepts. Basic concept, we know very well that we have two types of disease. One is the obstructive airway disease. and second one is restrictive airway disease. FEV1 is reduced markedly. It is reduced. Point to be noted, in both are reduced. In FEV1 is reduced in both, but it is markedly reduced in obstructive, is mildly reduced in restrictive. FVC, forced vital capacity, it is reduced. It is markedly reduced. That means both the values are reduced in both the diseases, but you cannot differentiate by single value. So what we go is we check for FEV1 FVC ratio. Okay, FVC ratio. This ratio is highly reduced in obstructive airway disease, and it is maybe normal, N for normal, or increase in restrictive airway disease. What I want to convey the message to you is both the values are reduced in both. So you cannot check, but we cannot decide by single value regarding to differentiate between obstructive and restrictive. You go by ratio. This is very, very important point. This is universal question is there. And one more thing, if you now you can see FEV1 is reduced in obstructive airway disease. Now if you want to know the severity of a case of obstructive airway disease, you check by FEV1. So the two important points that you got to know in this particular question. Now example of obstructive airway disease, it is bronchial asthma, COPD, bronchiectasis, and example of restrictive airway disease, that include pneumonias, it include interstitial lung disease. ILD stand for interstitial lung disease. ARDS, acute respiratory distress syndrome. There are some of the example of restrictive airway disease. So with this background, in restrictive airway disease, FEV1 FVC ratio is increased. Total lung capacity and residual volume are reduced. Vital capacity is reduced, it's not increased. So now you are clear about it. Why the right answer in this case is D. He says except. So all changes are seen except vital capacity is reduced markedly, is not increased. Well, all the following are useful in the treatment of patients with acute bronchial asthma except. The answer is Montelukast. This is the drug that we use. We do not use in acute attack. So let's learn the basic concept. What are the drugs that we use in acute asthma? So in acute asthma, the drugs that we use are, in acute asthma, we use are beta-2 agonists. The classical example of this drug is salbutamol. Okay, salbutamol is the example. Okay. Well, I have a question for you. Quickly write down the answer in your copy. Tell me any other use of salbutamol. Of course, we are using in asthma and we are using in case of COPD also as a bronchodilator. And a very important question, it is used in which other condition? Quickly write down the answer. In which other condition salbutamol is used? Well, the answer is we also use in acute hyperkalemia, in the treatment of acute hyperkalemia. This is a rank number 1 question. Rank number 1 getting question is this, the salbutamol is used in a treatment of acute hyperkalemia. One more question, again rank number 1 question, write down the answer in your copy quickly. Tell me one of the major side effects, very important, a very frequent side effect of salbutamol. Quickly write down side effect. Well, the answer is tremors. These two are the very frequently asked question and the rank number 1 getting question for you. So we are talking about various drugs that we use in the treatment of acute attack. Now I like to talk again a very commonly asked question. We have a drug called salmeterol. It is again a beta 2 agonist, but it is not used in acute attack. It is a long-acting drug. So we use in the treat as a prophylactic drug. We use as a prophylactic drug. It's not used in acute attack. Very, very important point. So other drugs that we use in acute attack are steroids, usually steroids. Hydrocortisone, is the drug that we use very often. We can use steroid in the form of inhalation also. Even beta 2 agonist drug, this can also be used as an inhalation nebulizer, you can say. Then we have ipratropium bromide. Okay. Ipratropium is again a drug that we use in asthma. Of course, we use in COPD also. Now the question is, again, write down the answer in your copy quickly. What is the mechanism of action of this drug? Is a very commonly asked question. The answer is, it is an anticholinergic drug. It's a very frequently asked question. FAQ is frequently asked question. Montelukast is a drug that we use as a prophylactic drug. Is it used for prophylactic drug? It's especially used in exercise. It's used in exercise induced asthma. It's not used in acute attack. Now let me tell you recent advances. Well, my dear friends, recent advances are again hot cake. Examiner are more likely to ask you latest drug rather than the routine drug. So you should know all latest drugs. So now I'll be talking about recent advances. RA will be recent advances or latest update. The new drug are omalizumab. It is a IgE blocker. Then we have mepolizumab and reslizumab. They are interleukin 5 antagonists. Interleukin 5 antagonists. We also have dupilumab, which is an interleukin 4 and interleukin 13 antagonists. So they are all latest drugs that you should know, so-called recent advances. Okay. Bedaquiline is used in the treatment of, again, a new drug, again a recent advances, and this question will surely coming to you, is used in tuberculosis. Okay. Well, if you talk about newer drugs that we use in tuberculosis are linezolid, amoxi and CLAV. CLAV stands for clavulanic acid. Clavulanic acid. Ofloxacin, clarithromycin, azithromycin. You can see these are the two which belong to question from pharmacology, macrolides. Okay, well, macrolide also include erythromycin, but in tuberculosis we use these two drugs. Okay, ofloxacin is a type of fluoroquinolone, and these are the drugs. Now I want you to make a special note. These drugs, which we are using as a newer drug for tuberculosis, if you closely look and if you recall your pharmacology, these are the drugs that we primarily use for Staphylococcus. Okay. Staphylococcus infection we use, and this drug in particularly is already the specific drug that we use for staph infection. So now we noted that these are the drugs which are anti-staphylococci are also effective against tuberculosis. And now I have a question for you. Write down the answer in your copy. We use that, we know very well that in tuberculosis we use INH, we use rifampicin, ethambutol, pyrazinamide, and streptomycin. This is standard that word we use for internationally for the treatment, anti-tubercular drug. Now my question is, write down the answer copy. Out of all these drugs that we are using for tuberculosis treatment, which one can be used for staph infection also? Quickly write down. Which of the following 5 drugs can be used for treatment of staphylococci also? Well, the right answer is rifampicin. This is a gold medal question, not known to majority of students. Rifampicin is a very good anti-staphylococcus agent also. So now again, if you just look into this thing, these are all the new drugs which we use for staphylococci, and we just got the new information that rifampicin is a very good anti-staphylococcal agent also. It means there is something common in the microbiology of staph and tuberculosis, tuberculosis. Maybe that all these concepts are not clear at the moment, maybe down the line after 20 years. You can find, or there may be new researches, they will show that staphylococci and mycobacterium, they belong to same family. Then that time, the treatment of tuberculosis will be just 7 to 10 days, 20 years back, later on. Today we are treating tuberculosis for 6 months. But later on, when things are more and more microbiology is clear, then maybe 20 years later, the treatment of staphylococcus or tuberculosis will be just like 7 to 10 days, the way we treat staph infection nowadays. Well, 20 years later, when you will be taking a class the way I am taking, you will be teaching your student, okay, nowadays we can treat tuberculosis for 7 to 10 days. Then you will say, well, when we were student in way back in 2021, we used to treat tuberculosis for 6 to 9 months. Okay, well, then the new things were not clear, but you will definitely say, yes, one gentleman, Dr. Bhatia, had told us a time will come when the treatment of tuberculosis is only for 7 to 10 days. Let us wait for that golden days. Now, clofazimine is the drug that we use primarily for leprosy. But now it is effective as an anti-tubercular drug. But these two drugs, bedaquiline and delamanin, this you should not forget. This will surely coming to you in your exam. So I'm leaking the paper to you, but in a very honest way. They are the 2 latest drugs, recent advances that we are using for the treatment of tuberculosis. So friends, this is the drug, bedaquiline is the drug that we use in the treatment of tuberculosis, not in other conditions. Well, question number 5. In acute pulmonary embolism, the most frequent ECG finding is tachycardia. Okay. This S1Q3T3, S1Q3T3, this is the most characteristic finding. But this is the most common finding. So there are two different questions. Tachycardia means heart rate more than 100 per minute. This is the most common finding, and this is the most characteristic finding. Let me tell you what are all these. So let's go to basics of ECG. Basic of ECG, if I have to tell you, we all know this ECG paper is like this. It's just like graph paper, very, very basic I'm talking to you. Just like graph paper, each square is of 1 millimeter by 1 millimeter size. Okay, the graph paper but we use in our school days. Let me draw a diagram for you. I got this wave. Yeah. So we are getting R wave and we are getting R wave. The first question is, if you have to calculate the heart rate, you quickly write down the answer. What is the heart rate of this strip in front of you? This is the wave. You got two waves. ECG graph paper is there. Calculate the heart rate in this patient quickly. Okay, the right how to calculate heart rate is 1500 divided by number of small square between two R wave. R wave, 1, 2, 3, 4, 5, 5. In this case, the heart rate is 300. So the first thing what we learned is regarding how to calculate heart rate. So whenever you are getting heart rate more than 100, we call as tachycardia. This is the most characteristic finding. Now, one more thing is we talk of P pulmonale. This P pulmonale indicate P pulmonale. Well, you can see normal P wave. Normal P wave is like this. Look into this. P wave. We are well aware this is the P wave. This is a P wave. So I have drawn a separate diagram. Normal P wave height and width both are less than 2.5 small square. You can see in this case it is almost only 2 small square. Width is 2.2 small square and the height is only 1.5 small square. So if you get a tall P wave like this, width is normal but tall P wave we call as P pulmonale, that indicate right atrial enlargement. Is a right atrial enlargement. That classically that we can see in tricuspid stenosis. Now let me tell you something extra. Suppose you get a P wave like this. What you are getting, we are getting a wide P wave. Wide P wave, height is normal but is a wide P wave. The wide P wave, when it is more than 2.5 small square, we call as P mitral. P mitral. That we see in left atrial enlargement. Left atrial enlargement. Now let me talk about what is S1Q3T3. This is the L1. I hope you know L1 lead. You get a S wave in L1 lead. What we write as S wave in L1 lead, so we write as S1. Similarly, we get lead, L3 lead. You get Q wave and you may get T wave inversion. This is Q wave and we are getting T wave inversion. Inversion means it is going inverted down. So this is so-called Q3 T3. This is the most characteristic finding. Okay. Now come the gold medal question. Gold medal question is, we talked about the classical thing that we get in case of pulmonary embolism is tachycardia, most common, and S1 Q3 T3 is the characteristic. Now, can we get, what is the paradoxical finding? What is the paradoxical finding that we can get in a case of pulmonary embolism? Gold medal question is this. Rank number 1 question. Write down the answer quickly in your copy. In ECG, sometime we can get a paradoxical finding. What is that? The answer is bradycardia. Paradoxical means all unexpected. We always get tachycardia, the most common, but sometimes we may get bradycardia, which is out of the blue. Does happen. And the word we use is paradoxical bradycardia is a gold medal question. The question comes is, paradoxical bradycardia is seen in, and believe me, this question is not known to 99% student. They do not know, but you know the answer because you are the topper. You are the top rank getting student. These questions are meant for people like you who deserve top rank. So you are clear about it, that when we talk about most frequent finding is this, most characteristic finding is this, and P pulmonale is right atrial enlargement. And remember, we can get that paradoxical bradycardia can occur in some case of pulmonary embolism. Now, two about MODY, autosomal dominant. So again, we go to basic concept. What is MODY? The full form is maturity, onset, diabetes of young. MODY. MODY. Well, this is a classical thing, MODY. The classical feature is seen in young people, usually below 25 years. And one of the most important and most frequently asked question about MODY, it is autosomal dominant. The answer is dominant. That means, it means there will be a definite family history will be positive. The family history will be definitely positive in these cases because it's dominant. It's a type of type 2 diabetes. Okay, it's a kind of type 2 diabetes. But serum insulin level is reduced. Something very strange. Now this finding normally we see in type 1 diabetes. But I said this is seen in kind of type 2 diabetes. Again a type 2 diabetes, but still obesity, hypertension, they are not the feature. They are not seen. It's a simple, non-obese, normal person. And now comes the gold medal question. Why, again, write down the answer in your copy, why this serum insulin level is reduced. And second question, what is the treatment of this condition? That means the patient or MODY come to you, what is the treatment you like to give in this patient? So quickly write down the answer in your copy. Okay. Why serum insulin level is reduced? Of course, there are no autoantibodies. It is this point which differentiates it from type 1 diabetes. We know very well in type 1 diabetes, which is the autoimmune, there are autoantibodies are there, but here we don't have any autoantibodies. But question is, why serum insulin is reduced and why? What treatment? Well, the answer to this question is, normally these beta cells are there. And beta cell has insulin, this is beta cell. I for insulin. Normally, after eating food which is digested, it gets converted into glucose. Glucose will come and act on the beta cell, and that causes release of insulin. Insulin comes out, glucose will act on the beta cell and it will trigger the release of insulin. Now in this patient, this sensitivity is reduced. Glucose comes, but it cannot push out insulin. That's why the serum insulin level goes down despite beta cells are normal. They are normal functioning. There is no destruction of beta cells, just like in type 1 diabetes where the beta cells are destroyed. Beta cells are normal, but they do not respond to glucose. So treatment of this is low dose sulfonylurea. SU stands for sulfonylurea. Why? Sulfonylurea will also, what's the mechanism of action of sulfonylurea? Sulfonylurea, they come and they act on the receptor and they cause the release of insulin. So sulfonylurea has the same action what is done by the glucose, right? So, but in case of MODY, the beta cells are not responding. Sulfonylurea is more powerful. So that's why sulfonylurea is also known as insulin secretagogue. Well, I can give you a day-to-day example also. Day-to-day example. This is a carom board. We all have played carom board and there are holes. Lines are there. And there is a striker. Here is a striker. Here is the coin. You use a striker and you try to put this into the hole. Yes. Now you are using this striker. It comes, but your power what you use is very less. So this coin may come up to this place, but it doesn't enter the pot. Why? You have hit it slowly. It's not powerful enough. If you give a powerful, it will straightway go to this. So exactly same thing. In MODY, glucose comes, but it's not that powerful to release insulin. Effect is not that powerful. And when we use sulfonylurea, which is much more powerful, that's why sulfonylurea are also known as insulin secretagogue. That means they cause release of preformed insulin. And now comes the gold medal question from pharmacology. Tell me any other drug you know of which is also insulin secretagogue. Write down the answer in your copy. Question is, tell me any other drug you know of which is insulin secretagogue. The answer is meglitinide. The group of drugs which include repaglinide, okay. So these are all insulin secretagogue. One more question. That's why sulfonylurea should not be combined with meglitinide because they both have the same mechanism of action. Again, a very commonly asked question. These are the gold medal questions from pharmacology for you. So now if you look into this thing, obesity is not a feature. More common in type 1? No, it is a type 2. Hypertension is usually there? No, hypertension is not there. So we are very clear about MODY. Now we talk about pre-tibal myxedema is seen in grave disease. Well, this is the most common wrong answer. In hypothyroid, you get myxedema is seen. Which is nothing, is bilateral, swollen legs. And this is due to deposition of subcutaneous mucopolysaccharide. Subcutaneous deposit of mucopolysaccharide which lead to non-pitting edema. Non-pitting edema. Legs are swollen, but you don't get edema. These are the gold medal questions. Non-pitting edema, mucopolysaccharide from biochemistry. Okay, this is myxedema that we get in hypothyroid. Now, what about grave disease? The grave disease, answer is grave disease. Grave disease is a triad of hyperthyroid, ophthalmopathy, dermopathy, okay. Now, pre-tibal myxedema, what we discussed just now, it is a type of dermopathy that we see in grave disease. Grave disease, dermopathy. So this is not seen in Hashimoto, it's not in hyperthyroid. There are many causes of hyperthyroid, but the skin sign, pre-tibal myxedema is seen only in grave disease, which is a autoimmune disease. Grave disease is a autoimmune disease. Okay. So we are clear about it. What is hypothyroid? What is myxedema? Which is pre-tibal myxedema? Both are you clear about it. Now let me show you some of the pictures. Lovely, I'll be showing you a lot of picture also. You can see this is proptosis, bulging of the eyes. This is pre-tibal myxedema, the point which I discussed in the previous slides, which we see in grave disease. We also see clubbing. In grave disease, and this is known as thyroid acropathy. Okay, this is not known to 90% students are not aware that clubbing is a feature of grave disease. Okay. So we are very clear about it. Next question number 8, brown tumor is seen in. It is seen in hyperparathyroid. So that we will never understand unless we know the basic concept. Well, rather before I go to about this question, which is a question of rather radiology, I'll first like to talk about histology. And one question, very simple question. Anybody who will answer this question correctly will get a cup of coffee as a treat. Write down the answer. What is the difference? We all know very well. In the bone histology, we have a cortical bone and we have a type of cancellous bone. Simple. What is the difference in the histology of the two bones? Question from basic sciences. And I promise, write down the answer. If you write the answer correctly, you get a cup of coffee as a treat. Don't worry, at the end of the lecture, I'll give you my contact detail also. Okay, done it. So, brown tumor, which is a question of radiology, you will never understand unless you know the basic histology, physiology, then pathophysiology, everything we learn. First, we talk about normal histological examination of the cortical bone. This is the cortical cut section of cortical bone. This is the central canal. These are lacunas, empty spaces arranged concentrically. And this is known as Haversian canal system. In the center, we have a cell called osteoblast. It is a bone forming cell. It creates the new bone. That's why in the cortical bone, growth occurs from inside outward. Because the bone is growing from inside, it will go outside. This is the osteoblast. And one more question from biochemistry. Whenever the osteoblastic activity increases, this increase ALP, alkaline phosphatase level is increased. Okay. Similarly, we have one more cell here, so-called osteoclast. It is a bone resolving cell. That means at any given time in the adult bone, around 5% of the bones are under constant repair. Damaged bone is removed by the osteoclast and it is repaired by the osteoblast. Then in these lacunas, we have cells. We have cells which are known as osteocytes, which maintain day-to-day activity of the bone. It means we got three types of cells. One is the bone forming cell, osteoblast. One is the bone maintaining cell, so-called osteocyte. And we have a third cell, which is the bone resolving cell, is the osteoclast. Well, just like in Hindu mythology, they say, Brahma Ji is the creator of universe. We have a osteoblast which creates the bone. Vishnu Ji is the mentor of universe. We have a osteocyte which maintains the bone. And finally, Shiva, which remove all the bad element from the earth. We have a osteoclast which remove all the bad bone. So creator, mentor and destroyer, Brahma, Vishnu and Shiv, you will never forget the histology of the bone whole life. Now let me tell you that what happened in cancellous bone. Cancellous bone are like this. They don't have central canal. Central canal is not there. And the cell, blast, class are there. Blast and class are on the surface. And these are arranged in parallel. They are arranged in parallel. Okay, with the result, these osteocytes are in the parallelly arranged, not concentrically arranged. This is the difference between cortical and cancellous bone. With this background of histology, now we come to physiology. So in case of hyperparathyroid, normally osteoblast and class activity are in parallel. Blast and class are in normal range, no problem. Okay, class. So whatever are getting removed or same is getting deposit, the bone is maintained in the normal shape. We know very well in hyperparathyroid, the class activity is much more. Class activity is much more than the blast. So it will try to resolve more and more bone. So let's learn about physiology. Physiology. So now let's correlate our histology with the physiology. It will try to resolve the calcium. More and more calcium coming out. That's the mechanism why hypercalcemia occurs in hyperparathyroid. This is a basic mechanism. Okay, now what is happening? Now what is happening in the bone? It is removing these calcium. So now these lacuna, they become bigger. Bigger. Day-to-day example, suppose in a room, this the room, there are chairs are there. Assuming a classroom, chairs are like this. And you remove certain and like this, room is full of the chairs, no space. Now what you do? You remove certain chairs. Oh, you are getting empty space. You remove more chair. Oh, you are getting empty space. Exactly same thing happening here also. So we are removing this lacuna, or what we can say, the empty space become bigger, it become bigger. And finally, it may coalesce to make a big empty space. And now this big empty space may get filled with liquid. And this is the basic pathophysiology of the mechanism, what we call as bone cyst. The basic pathology why and how bone cyst is made. Or if not, it may even may get fibrosed. It may get fibrosed. And this is so-called and fibrose. And when we look into X-ray, when you take X-ray, it looks like a tumor. Tumor is not there. Look like a tumor, what we call as brown tumor. The brown tumor is not a tumor. Very frequently asked. This question is asked throughout the world. Very frequently asked question. Bone cyst, the question from orthopedics, very radiology also. Very commonly asked. The brown tumor is seen in hyperparathyroid. It is not seen. It's not seen in other condition. This answer. Let me show you. So this is just see beautiful picture. Lovely photo, typical exam question is there. You are getting a type of brown tumor, looking like some tumor is there. And you can see one more thing, brown tumors are there, right? Well, we also get in X-ray, when you take an X-ray of skull, you get small dots. Look into this. I can enlarge the picture also. What we call as pepper pot appearance. Very frequently asked question. But as the bone gets resorbed, look into this. This is the radial side of the fingers. It get resorbed. Radial side. Now what is this? Look, hand. Look at this thing. You are all aware, this is the this ulna and outer side is the radius. So here also you will be getting resorption of the, if you look into this, radial side of the phalanx. Okay, I hope you can see it like this, radial side like this, outer side. And this is the most characteristic finding. Even there may be resorption of terminal phalanx. There may be resorption of the terminal phalanx also. Classical exam question. This is the typical, this is the most characteristic finding that we get in a case of hyperparathyroid. Okay. Next question. All are cause of hypercalcemia except chronic renal failure. Well, let's learn more about what are the causes of hypercalcemia. There are certain endocrine causes. In the endocrine causes regarding hyperparathyroid that we know, and we know the basic mechanism also, because it's all due to increased activation of the osteoclast. But in hyperthyroid also some amount of hypercalcemia can occur. It can occur in pheochromocytoma also. It can occur in Addison disease also. So friends, okay, thyroid, pheo and Addison are the thyroid, P for pheo, A for Addison, and thyroid, PAT. Mnemonic to remember is PAT. Of course, this is known to all of you. Point to be noted, hypercalcemia occur in other than parathyroid also. Cancers, breast cancer, squamous cell lung cancer. This question comes in all the exam. Why it is so important to talk about squamous cell cancer? This is a universal question, very frequently asked question. Okay, this question came in FMGE exam so many times. Now the question is, why to spend time? We know very well in lung cancer, typically small cell cancer of lung, small cell cancer of lung. There are a lot of neuroendocrine feature. But hypercalcemia occurs in squamous cell, not in small cell. Renal cell carcinoma, multiple myeloma and lymphoma, they can also lead to hypercalcemia. Out of these, this is very important, and second important is multiple myeloma. Don't forget these two. These are the one which will be getting rank number 1 for you. Most important. Lithium and thiazide, cannot afford to forget this. Lithium and thiazide. We know very well lithium we use in psychiatric manifestation. One of the side effects is hypercalcemia. Now again, a very, very important and very commonly asked question. There are two other important side effects of lithium. Write down the answer in your copy. Okay, which are the two other important side effects? The answer is, first of all, it can lead to polyuria. Why polyuria? And number 2, it can lead to thyroid dysfunction. Hypercalcemia, polyuria, and thyroid dysfunction. Regarding thiazide, quickly write down the answer in your copy. It can lead to which metabolic disturbance in the body? Quickly, very frequently asked question. Write down the answer in your copy. Which dysfunction? It can lead to hyperglycemia. It can cause diabetes. It can precipitate diabetes. And in the same question in pharmacology, they ask, thiazide should not be given. Which of the following diuretics should not be given in diabetic? Answer is thiazide. Very, very important and rank number 1 getting question. Vitamin D intoxication, vitamin A intoxication, simple. Milk alkali syndrome, prolonged immobilization, a person is lying on the bed for a very, very long time, for weeks, months together, it can lead to hypercalcemia. But out of these sarcoidosis, this is a very, very important question, rank number 1 question. So friends, if I have to talk about rank number 1 question, this is the rank number 1 question. This is the rank number 1 question, squamous cell, thiazide lithium and sarcoidosis. Don't forget this one. Other you forget, I don't mind, but don't forget this one. Now a very commonly asked question, how can sarcoidosis or granulomerular disease can lead to hypercalcemia? Write down the answer quickly in your copy. Is a very frequently asked question. Well, the answer to this question is, normally, let's learn the basic biochemistry. We all know very well 25 hydroxylation of cholecalciferol. Cholecalciferol. This occurs in the liver and it is converted into 1,25 dihydroxy cholecalciferol. C for cholecalciferol, which you already written, I am writing C only. This reaction needs PTH and this reaction occurs in kidney. But in condition like sarcoidosis, this reaction can occur outside the kidney also, what we call as extrarenal formation of vitamin D. So granulomerular tissue themselves can make vitamin D. That means there is another factory where they are making vitamin D, and that's the reason why it can lead to hypercalcemia. This is true for condition like tuberculosis also, because tuberculosis is again a type of granulomerular disease, but classically in the exam they always talk about sarcoidosis, but at the back of the mind you know that this can happen in any of the granulomatous diseases. Well, all are feature of Cushing disease except the answer is episodic hypertension. This is seen in pheochromocytoma. It's not seen in Cushing syndrome. In Cushing syndrome, we do get central obesity, so-called truncal obesity, easy bruising, what we call as purple stria, glucose intolerance means it leads to hyperglycemia or it can precipitate diabetes. They are seen. So first I tell you the basic concept. Why hypertension occur and why hyperglycemia occurs, that you will never understand unless you know the basic concept. First of all, they lead to hyperglycemia. Why? We are all aware in Cushing syndrome there is excess of steroid. This excess of steroids, it can lead to increased gluconeogenesis. Glycogen increase, glycogenolysis, and they contribute to hyper. These two mechanisms are the reason why high blood sugar occurs in case of Cushing syndrome, all because the steroid lead to this problem. Now, why hypertension occurs? For that, we go to the basic concept. The question is why hypertension occur in case of Cushing syndrome. So normally we all know, if you talk about normal physiology, we have a aldosterone, A for aldosterone. The normal physiology we know very well, this it absorbs that aldosterone act on the DCT and collecting tubule. It absorbs, maybe 2 sodium are being reabsorbed. Water follows passively. Now we all know that when we talk about natural steroid is cortisol. Cortisol also have a mineralocorticoid activity. And due to mineralocorticoid activity, it also tend to absorb sodium and water. And just now we talked about this. This is so-called glucocorticoid activity. So steroid raise the blood sugar by glucocorticoid, and they also have mineralocorticoid activity, which is just like aldosterone. So that's why I have written aldosterone, just for better understanding. So now in Cushing syndrome, there is excess of cortisol. That means more and more mineralocorticoid activity. So now maybe 4 sodium are reabsorbed and more water will be absorbed, and ultimately it will lead to increase intravascular volume. It lead to increase intravascular volume, and that is the reason they will lead to increase BP. This is a constant phenomenon, not episodic. That's a basic mechanism why and how hypertension occur in a case of Cushing syndrome. Right now, in Addison's disease, reverse will happen. In Addison's disease, there is no cortisol, there is no aldosterone also. So sodium and water will not be reabsorbed. And one more thing, not reabsorbed. One more thing, that now whenever sodium are getting absorbed, like initially there are 2 sodium are absorbed, body has to secrete 2 positive particles. Why? Law of electrostat. 2 positive in, 2 positive go out. Now in case of Cushing syndrome, 4 sodium have come in, that means body will be losing double H ion, double potassium. That's the reason why hypocalcemia occurs in Cushing syndrome, and that's why metabolic alkalosis occur. Why metabolic alkalosis? Because large amount of H ion has been secreted into the nephron. Okay, this is what happened in Cushing syndrome. Now in Addison disease, the sodium and water will not be reabsorbed, so they will be reduced in Addison disease. There is reduced intravascular volume. That lead to low BP. And moreover, cortisol level is reduced. There is reduced blood sugar. Why? Reduced glycogenolysis and reduced gluconeogenesis. So blood sugar is reduced, BP is reduced. That's why, due to these 2 reasons, the commonest presenting feature of Addison disease is fatigue. Fatigue malaise, and so-called asthenia. Asthenia occur. Fatigue malaise is the feature of Addison disease, low sugar and low BP. With this background, we come back to now we are clear about it. Well, other feature that we see in Cushing disease, I told you, so let me show you some pictures. So you are clear about glucose intolerance. Now this is the buffalo hump that we see in Cushing disease. Moon-shaped face. Classical picture. Okay, this is the purple stria. This is due to easy bruising. Look into more of the bruise. Hirsutism can be there in Cushing syndrome. This is due to increased androgens. Hirsutism is seen in Cushing syndrome. Well, this question partially I discussed in the previous hyperglycemia. So we learned in the previous question in Addison disease hypoglycemia occurs. Hypotension, yes, we know, and we learned the mechanism also. This is due to reduce intravascular volume. Hyperkalemia, because potassium is retained in the body because sodium is not getting reabsorbed. Potassium remain in the body, that lead to hyperkalemia. Hyponatremia, because sodium is not getting reabsorbed. Hyperglycemia is not a feature of Addison's disease. Well, one more finding that we can see is hyperpigmentation. This is due to in Addison disease, ACTH level is increased, and ACTH and there has a MSH like activity also. ACTH is a hormone which is which stimulate cortisol secretion. MSH is a pigment, melanocyte, stimulating hormone, which causes increased pigmentation. That's why we get pigmentation, hyperpigmentation in Addison disease. But now comes the gold medal question, not known to 90%. In some cases of Addison disease, there can be even vitiligo also, vitiligo. But this is seen only in autoimmune variety of Addison disease, not otherwise. We know very well Addison disease or hypoadrenalism can occur due to so many causes. But in autoimmune variety, we may get either hyperpigmentation or we may get even vitiligo also. Look into this. So if you are getting this vitiligo and patient is a hypoadrenalism, we are sure we are dealing with the autoimmune type of hypoadrenalism. Now write down the answer in your copy. I have a question for you that in India, most common cause of hypoadrenalism is a very simple but very frequently asked question. In India, the most common cause of hypoadrenalism is what? Write down the answer quickly in your copy. Answer is tuberculosis. So vitiligo occurs in around 10 to 20% patients with autoimmune Addison disease. Now is a very simple question. Which of the following is not a part of classical tired or diabetic symptom? Well, the answer is polyphagia. Most people go for weight loss. Answer is polyphagia. Okay. But you will say, but sir, I remember in my classes I was taught the classical tired is polyuria, polydipsia, polyphagia. I can show you, it is written in Robbins also, but that is written wrongly. Well, you can very well see Harrison 20th edition, it is given there, classical triad. Well, एक movie आई थी, there was a movie called Munna by MBBS, and I'm sure all of you must have seen that movie. In that movie, if you recall, there was a scene, Sanjay Dutt, the hero, is made to sit on the stage, on a table and chair. And the people ask him a question. The question is asked to him, what is diabetes? Sanjay Dutt, the hero, answered like this. Diabetes is a state of condition where we have a polyuria, excess of thirst, so-called polydipsia, and unusual weight loss. Even the Munna Bhai knows the classical triad is polyuria, polydipsia, and weight loss. तो next time when you will see this movie, when the scene comes, जब ये scene आएगा, तो definitely you will thinking about me. And Dr. Bhatia talked about the diabetic symptom, the classical is polyuria, polydipsia, and weight loss. Polyphagia is a feature of diabetes, but it's not a classical type of diabetic symptom. Well, the characteristic feature of frontal lobe tumor is antisocial behavior. The answer key given to you, there was a typing error, but the right answer is antisocial behavior. Why this answer? That you will never understand unless you know the anatomy and physiology of the frontal lobe. The lobe, this central sulcus. I'm talking about cerebral hemisphere. Central sulcus, the part, this is a motor cortex, which lies, this is a central sulcus. Central central sulcus, and this is the motor cortex. The part in front, in fact this whole is frontal lobe. This whole is frontal lobe. Let me draw with a yellow color. This whole is frontal lobe. We have a lateral sulcus. This is lateral sulcus. Okay. This is parieto-occipital sulcus. Parieto-occipital sulcus. This is the occipital lobe. This is T for temporal lobe and P for parietal lobe. Too simple at your level. You are all learned people. So, as of now, we'll talk about frontal lobe. Well, frontal lobe, this is one area in the very frontal part. If you can keep your hand in the very proximal part of your head, this is the prefrontal cortex. This is the prefrontal cortex. This area, which I have marked like this area for social behavior. And personality. Yes. Area of social behavior and personality. This is the anatomy. Now let me discuss physiology. I said prefrontal cortex is the area of social behavior and personality. What do you mean by physiology? Well, you come to the college class, you wear your normal dress. You go home, when you are about to sleep, you change your dress and you wear nightie, pajama and slipper, etc. when you reach home. Can you come to the class with the same dress? No way. You cannot come to the class with nightie, chappal, pajama, etc. etc. Why? We have an area of social behavior. We decide which dress is to be worn or which is not to be worn. Okay. Well, let me give you one more example. You are attending the class in your college, and after the college you have to go to a function. And remember, you are wearing the usual college dress. Can you or will you go to that function with the same dress? लड़के तो चले भी जाएंगे. Boys can go, they don't mind. But ladies, no way. I can guarantee 101% none of the lady who is listening to me will say, I'm going. They will never go. Never. Why? Ladies want to get dressed up in the best possible way. Boys are hardly, males no problem. And I tell you one more thing which none of you know, that in ladies, of course, this I talked to you regarding area of this social behavior. This one I'm talking about, area of social behavior personality. Anatomically, it is the size is same in both men and women, boys and girls. But I tell you, it is much more functional, much better functioning in ladies. The point what you don't know. Ladies have a much better observation power. For us, this is yellow color. This is yellow color. But for lady, it is a haldi yellow and or sunflower yellow, light greenish yellow. All our yellow shades are different because they can differentiate much better than what we can differentiate. Okay. And the area of, well, you agree with me? Yes, you all agree with me. Yeah. But remember, anatomically, they are same. Well, now this is that due to this area of social behavior personality, we have to abide by the rules of society. We go by rules of society. You are driving the car in a main road, you drive very carefully because it's a rush area. If you drive rash, you might do some accident. Now what happened? After you have taken, somebody have taken the alcohol, that inhibition is gone. Now he will drive the car in a very full speed, in a very rush area, bound to do some accident. That's why when you go to road, it is written, don't drink and drive, don't drink and drive, sharab pee ke gaadi na chalaएं. This is the reason, because that social inhibition is gone. Well, I told you when a person take alcohol, that social inhibition gone. Even language changes. They say in India, maximum English is spoken in which state in India? They say from 8 a.m. to 8 p.m. it is Kerala. But after 8 p.m. it is Punjab. Well, Punjabi fellow will have a bottle of whiskey and he will forget Punjabi and start speaking English, or what we say, Punjabi छोड़ के अंग्रेजी बोलना शुरू कर देगा, Punjabi छड़ के अंग्रेजी बोलना शुरू कर देगा. Those who know Punjabi, they will understand me better. So this is all area of social behavior personality. So definitely now we go to pathology and psychiatry aspect. If this is damaged due to any reason, the patient will have a antisocial behavior. Antisocial behavior will be there. Okay. And this will be seen in cerebellar disease. And this will be seen in, again, brain stem lesion, or this is seen in bulbar palsy. This is seen in temporal lobe lesion. So this is seen in frontal lobe. I hope things are clear to you. Cortical blindness is seen in occipital lobe. Why this answer? Let's go to basic anatomy and physiology. Then we go to ophthalmology. Anatomy and physiology, this is the brain, this is the eye, optic nerve, and this they go to occipital lobe. So like you are watching me, you are watching me with your eyes, and it's the optic nerve. ON is optic nerve, which is taking impulse to the occipital lobe. So it's the occipital lobe where actually film is getting made in your brain. So definitely if some lesion occurs in occipital lobe like this, so what happens? Picture will not form. Although eyes are normal, optic nerve is normal, both are normal, N for normal. But still the person cannot see because the lesion occurs in the where actual film is getting made, and this is so-called cortical blindness. cortical blindness is what we see in occipital lobe lesion. In parietal lobe lesion, in dominant parietal lobe lesion, you get Gertzmann syndrome. In bilateral temporal lobe lesion, you get Kluver-Bucy syndrome. The Kluver-Bucy syndrome, bilateral temporal lobe lesion. What are the features of Kluver-Bucy syndrome? Apathy, orality, hyperphagia, increased sexual activity, increased sex desire. They are the feature of bilateral temporal lobe lesion. Well, let me give you a day-to-day example. Suppose there's a patient, young patient of 20-year or 25-year got admitted in your ward, and the history given that he had a roadside accident, and the MRI shows bilateral temporal lobe injury is there. So you go in the morning, you take around and you say, "Kya haal hai iska? How is he?" Patient attendant will say, "Doctor, since the time of accident, he is always lying on the bed like this, nothing doing." So-called apathy. Apathy means sust baitha hua hai, doing nothing. And the patient attendant say, "But we don't have any problem with this." What else? You say, when we wake him up, he will try to touch everything with the mouth, like, "Look at me." So-called orality. Patient attendant say, "We don't have a problem with orality also." Then what else? When we wake him up for food, he eats a lot. He eats so much that he takes his own food and he eats our food also. Attendants say, "We don't mind for that also." Then you ask, "What's the problem? Where's the problem?" Sir, the problem is when the nurse comes to check his pulse BP, he does all teasing to the nurse. Friends, golden line to remember: patient taking panga or teasing the nurse is Kluver-Bucy syndrome. Don't forget. Increased sex desire. So if you are getting roadside accident patient and they're teasing the nurse, you think about Kluver-Bucy syndrome. Okay? So you are clear about each one of them. Then we talk about speech. Broca's area is located. This question come speech, a very commonly asked question in FMG exam. So first we learn the anatomy, then we learn the physiology, then we learn the neurology, and then we learn the medicine also. So let's learn anatomy and physiology. First we learn about anatomy. This is a central sulcus. We learn this is what? Lateral sulcus. This is what? Parieto-occipital sulcus. In the posterior part of temporal lobe, we have a auditory area. We have auditory area. This one. In the superior temporal gyrus, we have a Wernicke area. And this is the motor cortex. We learned leg area is at the top and the head area is the bottom. Point to be noted in the cerebral cortex, body is hanging upside down. Leg area is the top and the head area is at the bottom. Then we have in the inferior frontal gyrus, we have a Broca's area. Broca's area is a motor speech area. It lies in the inferior frontal gyrus. And I talked to you that Wernicke areas lies in the superior temporal gyrus. And we also know very well these are located in the dominant hemisphere. Dominant hemisphere we call as, if you are right-handed like the way I am right-handed, most of you are right-handed, then in our case it is left sided, they say dominant. In lefty people, they more of a right-sided dominant is there. Okay, this general, of course exceptions are there, but anyway by and large general consensus is left hemisphere is more dominant. This is the anatomy, and these two are attached to each other via arcuate fasciculus. These two are attached to each other via arcuate fascicle. This one. This blue color. That means Wernicke area and Broca's area are attached to each other via arcuate fascicle. This is the anatomy. Now let's talk about physiology. We have to learn in an integrated way. So let's integrate with physiology, then we'll integrate with medicine also. Like I asked you, what is your name? My words, they go to your ears, from ears they go to auditory area. It is there in bilateral, both these temporal lobe, bilateral. From here the message comes to Wernicke area, which is lying in the superior temporal gyrus in the dominant. I presume you are right-handed, it will go to your left dominant cerebral hemisphere in the Wernicke area. Here speech is understood. My question was, what is your name? You listen and it goes to your Wernicke area where you could understand, oh, my name is being asked. Now this Wernicke area will send a message to Broca's area via arcuate fasciculus. Broca area is a motor speech area. Now this will give a command to head area. God is the greatest engineer. It has made Broca's area quite near to head area. Now the head area will give, my name is XYZ. That's the basic physiology of speech also. I hope you are clear about this. So, a quick recap. What is your name? They go to ear, they go to bilateral auditory center in temporal lobe. They come to dominant temporal lobe in the superior temporal gyrus in the Wernicke area where speech is understood. That's why Wernicke area is also known as sensory speech area. And the message will come to Broca's area, which is a motor speech area via arcuate fasciculus, and Broca's speech area will give a command to vocal cord lips, and the answer comes, my name is XYZ. Now let's correlate anatomy physiology with medicine. Suppose there is one patient who is suffered head injury and he got injury in the Wernicke area. To him you ask, what is your name? Your word goes to his ear, they go to auditory area, yes, some sound has come. But now we come to Wernicke area, but he could not understand why Wernicke is not working. So now automatically he will say, you ask what is your name. Remember, Broca's is working normally. So you ask what is your name. No, I have taken my lunch. Arey yaar, tera naam kya? What is your name? No, I'll not go to movie. You are asking something, he is replying something. So in Wernicke defect, there is irrelevant speech. Irrelevant rapid speech is there. Why irrelevant? You are asking something, he is replying something. All senseless speech what we talk. Suppose you get another patient whose Wernicke area is all right. His Broca is damaged. You ask what is your name. Your words go to his ear, they go to auditory area. He understood. Your question is what is your name. He understood. He gives a command to Broca's, but Broca's area is not working, so it cannot give a command to head area. You ask what is your name. He is standing like this. What is your name? No reply. Will you go to movie? Will you take dinner? Arey, मुँह से bolo, speak out from mouth. He cannot speak. Will you go to a movie? He say, yeah, he like this. But he cannot speak. But he understood via Wernicke area. So in Broca's speech defect, speech outflow is reduced. Speech outflow is reduced. He is not able to speak out. Suppose Wernicke area is all right and Broca area is all right, and defect lies in arcuate fasciculus. In arcuate fasciculus, repetition is lost. Repetition is lost. Now come the gold medal question. Write down the answer in your copy. Tell me in arcuate fascicular lesion why repetition is lost, how it is lost. Anybody will answer this question correctly will get a cup of coffee as a treat. Write down the answer how, what the mechanism of repetition lost in arcuate fasciculus lesion. Well, I'm sure by now you have written the answer. Answer is, stop writing, listen to me very carefully. You ask the patient, what is your name? Go to auditory Wernicke and come to Broca's area. Yes, that's the mechanism. Okay. But when arcuate fasciculus is lost, is gone, you cut, maybe you are by scissors, you have cut it. Remember, his Broca's area is normal and Wernicke area is normal. There's no problem. Problem is arcuate fasciculus. So now he is hungry. He says, I want food. Why he can speak? Because his Broca's area is working normally. I want food. Now you say, what did you say? Please repeat. Now your words go to Wernicke area, but Wernicke cannot give a command to Broca's because in between there's no connection. So he's not able to repeat because message cannot go from Wernicke area to Broca's area. I hope you are clear about it. To summary is Wernicke area is senseless speech. In Broca's area, speech outflow is lost. Well, I'm sure you are tired by now. Let me give a day-to-day example. In Broca's speech defect, he's not able to speak out. Well, this happens normally also under physiological condition, more in boys. A boy loves a girl. A boy there, he loves a girl, but he doesn't know how to express. Okay. वो कहते हैं ना दिल की बात जुबान पे आए हम कह नहीं पाते हैं. That is a type of Broca's defect. और आपकी बात वो नहीं समझती है, दैट इज वर्निकेट डिफेक्ट। वैसे बताऊं, समझती सब है अपनी सहेली को, अपनी शी इज द गोइंग विद हर फ्रेंड, शी विल डू लाइक दिस टू हर फ्रेंड, लुक लुक लुक, ब्रोकास्ट डिफेक्ट, ब्रोकास्ट डिफेक्ट, दिल की बात जुबां पे आए ना कह पाए, ब्रोकास्ट डिफेक्ट। दोस्तों, जब आए बात तो कह डालना, वरना जिंदगी एक भर का पछतावा होगा। बात तो दिल में थी, वो सामने थी और मैं कह नहीं पाया। You will regret for whole life. So I hope you have learned about the basic concept about broadcast defect and Wernicke defect. Now things are clear to you. It lies in dominant inferior frontal gyrus, okay, and it is this location of Wernicke area. Okay. Most common cause of SCH, answer D है, and I am sure most of you have gone for this answer. It's the most common wrong answer, because trauma is the most common cause of subarachnoid hemorrhage. But here, so if suppose in this the option was some bleeding disorder, maybe it's bleeding disorder, this was the option number D, bleeding disorder. Then the answer would have been Berry aneurysm. But if trauma or trauma is there, again trauma is the answer. So answer here is none of the above. Friend, SCH is a VVIP topic. VVIP topic means दुनिया के हर एक एग्जाम पे इस पे सवाल आता है. There is not a single exam where question doesn't come on SCH. Universal. What question will come? The question occurs if sudden severe headache, sudden onset severe attack without fever. Usually fever is not there. If the question come like this is subarachnoid hemorrhage. And there may be neck rigidity. Which is seen in meningitis. But in meningitis, fever is a feature. Fever is usually not a feature in this. And now come the one more simple question. Which is the most accurate test to diagnose subarachnoid hemorrhage? Write down the answer in your copy. What is the most accurate test to diagnose subarachnoid hemorrhage? Quickly write down. Well, I'm sure you must have written the CT scan. This is the most common wrong answer. If they ask what is the first initial test, then the answer is CT scan. CT scan is positive in around 95% cases. In 5% cases, CT scan may be normal. In that case, you go for lumbar puncture. If you see RBCs in CSF, this is the most accurate test. So lumbar puncture is the most accurate test. Well, this is a CT scan. You can see blood. Okay. This is the normal CSF. Xanthochromia. The CSF turns yellow, but this happens if the CSF are done after about 6 to 10 hours. By the time the RBC get lysed and they give a yellow color, so-called xanthochromatic CSF. That's a classical thing that we see in subarachnoid hemorrhage. Well, the complication that can happen in a case of subarachnoid hemorrhage, vasospasm. And that's also the cause of long-term morbidity. Long-term problem occur due to vasospasm. To prevent this, we give drug like nimodipine. Then second complication is rebleed. Rebleeding can happen. There can be hydrocephalus. Now, there can be a electrolyte imbalance also. Write down the answer in copy. Which electrolyte imbalance can occur in a case of subarachnoid hemorrhage? Quickly write down the answer. Which electrolyte imbalance can happen in subarachnoid hemorrhage? The answer is hyponatremia. Low sodium, this is due to SIADH. Full form is syndrome of inappropriate secretion of ADH. Syndrome of inappropriate secretion of ADH. Excess of water is reabsorbed by ADH, and that is to hyponatremia. Gout is a disorder of purine metabolism. Okay. And purine metabolism that gives rise to uric acid. Simple question from biochemistry, but the question is, it is due to deposition of uric acid? No. The gout occurs due to monosodium urate crystals. What we write as MSU. It's this one which leads to gout. In this we get needle-shaped crystals. You get needle-shaped crystals. Okay. Most common joint involved is great toe joint. Well, we know it leads to gout. Gout, great toe joint, and it is red, hot, and tender. It's very painful. It is very painful, hot, red, tender. There may be tophi. Tophi is soft tissue. So you may get even deposition in the soft tissue, so-called tophi, in gout. You can see this. Okay, tophi. And of course, don't forget, they may even make uric acid stone also. They may do uric acid stone also. So the clinical feature of gout includes severe joint pains, I told you. The joint, great toe joint, rod, head, hot, red, tender. It's a type of inflammatory arthritis. Involvement of small joints, especially great toe joint, but it can involve joint of the hand also. I have shown you picture also. Look into this. This also, but most commonly great toe joint. It can even involve the ankle, knee also. And I told you it is a deposition of monosodium urate crystal, not uric acid, in the synovium. The initial site, the deposition occurs in the synovial membrane, and that's why the answer is all of the above. But I have got severe joint pains. it lead to grade 4 tenderness. Grade 4 tenderness. Now the question is again, simple question. Write down the answer in your copy. What are the causes of grade 4 tenderness? What are the causes of grade 4 tenderness? One is gout. What are the other causes of grade 4 tenderness? Well, now before I proceed further, let me tell you what are the grading of tenderness. Grade 1 tenderness is when you touch and you can elicit the pain. You touch, dard hai, pain hai, he says yes, I have pain. This is grade 1 tenderness. Grade 2 you touch, patient winches with pain is grade 2 tenderness. Grade 3 you touch, he withdraws. Oh doctor, he withdraws. Grade 3 tenderness. Grade 4 you try to touch. Doctor, don't touch, don't touch. Grade 4 tenderness. So grade 1 means you touch, pain hai, dard hai, yes I have pain, grade 1. Grade 2, Grade 3 he withdraws. Grade 4 he won't let you touch. Grading of tenderness, this is the rank number 1 getting question. Believe me, not known to 99.9%, they are not aware of this point. Now come the gold medal question again from orthopedic. What are the cause of grade 4 tenderness? Septic arthritis. This question from orthopedic, septic arthritis. It can occur in gout and arthritis occurring in rheumatic fever. Arthritis occurring in rheumatic fever. They are the cause of grade 4 tenderness. Okay. Now look into the needle-shaped crystals. Okay. Look into this needle-shaped crystal, classical exam question. This came in one of your FMG exam also. In fact, I have told you in the very beginning, all the questions that I have taken are from previous FMG exam. So you are actually getting the taste of the FMG exam. So we are getting these needle-shaped crystals are there, needle-like needles. This is the X-ray of gouty tophi. I have already shown you picture. Now if you take X-ray, you get a picture like this. And if you take a X-ray of the hand or any joint, you get G sign or mouse bitten appearance, also known as Martel sign. So what you get is a type of overhanging type of picture. Look into this. Look into this. Overhanging type of picture. So-called mouth bitten, overhanging, G sign. Okay, G sign also they would call as. This is what is X-ray of the hand and this gouty tophi. Latest, let's discuss pharmacology. We learned about orthopedic, we learned about biochemistry, we learned about medicine, clinical side. Now let's talk about febuxostat, newer drugs for gout, febuxostat. It's a new xanthine oxidase inhibitor. Of course, we are using allopurinol. But the new drug is febuxostat. Then we have a benzbromaron. It's a type of new uricose uric drug. It causes increased uric acid excretion in the urine is benzbromaron. Rasburicase. Normally what happens, this I told you is a disorder of purine metabolism. Normally purine is converted into uric acid. Now this will convert, rasburicase will convert urine into allantois. purine into allantois, which is a water-soluble molecule, it goes out of the body. But most important is losartan, fenofibrate and amlodipine. These are three well-known molecules to you. We know very well that losartan and amlodipine, they are the drug for hypertension. Fenofibrate is a drug to control lipid. So these drugs also have a uricose-uric action. They cause increased uric acid excretion. The question which came in FMGE exam, which is the drug of choice for hypertension? Drug of choice for hypertension in a case of gout. And of course, their option will be losartan or amlodipine. One will be there. I mean, your question it was losartan or anything else. This is the drug of choice. Okay, for patient of gout with hypertension. Okay, well, now I have one more question. Which is the drug which ARB? ARB is an angiotensin receptor blocking drug just like losartan. So losartan, the angiotensin receptor blocking drug, angiotensin receptor blocking drug, ARB. This we use drug of choice, gout is losartan. Now question is, which ARB should be used in diabetes? And why? Write down the answer quickly in your copy. Which ARB should be used in diabetes? Quickly write down the answer copy. This is a rank number 1 getting question. Answer is telmisartan. This is one ARB which also acts on PPAR gamma receptor. Telmisartan, of course, this is an anti-hypertensive drug, but it also acts on the PPAR gamma receptor, and we know very well that drug like glitazone, like pioglitazone, which is an anti-diabetic drug, it acts on the PPAR gamma receptor. So telmisartan has a mild anti-diabetic action also. Okay. Now we got a new lipid drug. We got a new anti-lipid drug. New anti-lipid drug which acts on the PPAR alpha PPAR gamma receptor. Write down the answer. What is the name of that drug? The anti-lipid drug which acts on the PPAR alpha and PPAR gamma receptor. Name the drug. After the drug. New drug. Latest recent advances. Saroglitazar. Is a one drug which is a anti-lipid drug which act on the PPAR alpha and PPAR gamma receptor. Let me tell you some of the newer anti-diabetic drugs. Okay, we have got newer anti-diabetic drugs. We got GIP, GLP-1 agonist, liraglutide, exenatide. We have DPP4 inhibitors. Okay, sitagliptin. So these are very, very important questions. So you are clear about many more questions regarding losartan, ARB. One more point which I would definitely like to mention in diabetes. Not only we have to control the blood sugar, but we have to control BP also, because many of the vascular complications, they can be cured, cannot be cured unless you control the BP also. So it's a mandatory for a diabetic patient to control blood sugar as well as BP. So we have to use the drug the most appropriate way so that BP and sugar are well under controlled. Okay. So now we take a break, tea break of about 20 minutes, and we see after 20 minutes. Don't go away. I hope you are all enjoying the class, and you can very well note down my email ID, dr.bhatia@dbmi. It is DBMI, not DBMCI. DBMI dot edu.in. Do give the feedback. How was the class? And of course, we are going for tea break. Don't disappear. Come back in 20 minutes and we continue with more discussion. Thank you very much. See you in 20 minutes.